And what about the issue of single payer in this country? You write about that as well in this article, talking about France, looking at Great Britain. There has been single payer was off the table from the beginning of the conversation about healthcare reform in this country. Do you think that's the way to go?
I'm not inherently against single payer, but I am. My questions have always been not about what is our idealized system, but how do we get there from here?
And explain what you mean by single payer.
And by single payer would mean having a single government-run insurance program, Medicare for everybody. That would be single payer. And as a physician, all I can tell you is I don't care if it's Medicare for everybody, a group of private insurers. It is better than what we have now, which is a mess, and is not leading to better care or sense about how we're handling costs. The fact that we're taking steps forward and organizing ourselves, we're a country where we've been a mixed model. We've had about 50% of the country is on government programs like Medicare and Medicaid, and about 50% on private insurance. And in each system, people are mainly fearful of losing what they have. And addressing that fear of losing what they have is what is at the core about reform. And as we build forward, this is going to be a test over time. Which system will serve people the best?
Do you think we could get to a single-payer system from what is being proposed now in Congress?
Yes, it's very possible.
How? What would that road look like?
The road, I think, is that we are now moving to a system of such significant insurance regulation that the insurance role of cherry-picking risk gets replaced with an insurance role of organizing care. And we have a Medicare system and Medicaid system that are trying to do the same thing. Over time, what we'll learn over the next decade is which system is helping drive better costs, which system is better organizing care, and what I think we're going to find is the most effective systems probably don't look a lot like Medicare and don't look a lot like Aetna or United. They look a lot more like Grand Junction, Colorado is dominated by a local insurer called Rocky Mountain Health Plan. And because it's local and they have feedback to know when the needs of their population are, they've been able to work in ways that have doctors, community people, employers, all on the same side, working to have a system that makes more sense, and it's resulted in higher quality and lower cost.
Let's talk about solitary confinement.
Yes, other article.
Yes, a totally different issue, extremely important. Talk about your findings.
And to me, at some level, these are not different issues. I mean, this is about what we think of ourselves as individuals facing large systems. And what bothered me about solitary confinement was that this is a generational change. We have we barely used solitary confinement even during the Reagan years, but during the last decade and a half, our use of solitary confinement has exploded. We have over 50,000 people now in long-term solitary confinement. It dwarfs the experience of any other country in the world. And what
do you mean by solitary confinement? Explain the actual circumstance of it.
It is just as you imagine it, small cells, usually about 10 feet by 12 feet or so. People confined and limited from having any social contact, maybe in some places an hour or so a day in a fenced-off area. I describe one set of cells where they call it the kennel because they literally put people out into dog kennels, runs that let them get a little outdoor time. But basically 23 hours a day of total isolation, and in many instances situations where you have no social contact with people for months on end, even with visitors or family. And what I did was I looked at the experience of hostages. John McCain, who spent years in solitary confinement in Vietnam, Terry Anderson, the journalist who was kidnapped in Lebanon. And their experience, the science of what happens to people deprived of social contact, is they have to fight for their sanity, and many lose their sanity. That reality, that we are social beings in our physiology, led me to ask the question, is solitary confinement, the way we're practicing it now, torture? And you can't read the cases, and I describe the cases of both hostages and people who are in prisons and conclude that, number one, those experiences are different. They're the same. Number two, you can't conclude that it's not torture.
What happens exactly? I mean, there's a physical change in the brain. Explain.
Yeah. Physicians took people who were confined in Serbia in concentration camps under conditions of isolation, and some of them were not in isolation but beaten. And they did brain scans, and they found that people who'd sustained head injuries had the same degree of brain injury as people who'd sustained solitary confinement for long periods.
I want to bring up a case, ask you about the case of Syed Fahad Hashmi, a young U.S. citizen who's been held in 23-hour-a-day solitary confinement for nearly 3 years. He's charged with providing material support to al-Qaeda in a case that rests on the testimony and actions of an old acquaintance who turned government informant after his own arrest. Hashmi's period in solitary confinement is believed to be one of the longest ever for a prisoner before trial. We spoke to his brother Faisal last summer. This is how he described the prison conditions of Faisal Hashmi, who's really just down the road from us right here in New York.
He has not gone to trial. He's a pretrial detainee. In a civilized society, a pretrial detainee kept in complete solitary confinement for 2 years. Within his own cell, he's restricted in the movements he's allowed to do. He's not allowed to talk out loud within his own cell. So imagine for yourself, you're a pretrial detainee, not convicted of anything, and you're held in these conditions where you're not allowed to move, not allowed to talk.
What do you mean move?
Certain movements within his own cell are censored. He is being videotaped and monitored at all times. He can be punished more than he's already being punished by denied family visits if they say his certain movements are martial arts or something that they deem as incorrect.
This is Faisal, the brother of Fahad Hashmi, who is in prison here, pre-trial detention, 3 years. He described how when he tried to exercise, to do martial arts, he was told he could not get in those positions. What is the physical effect on the brain of this level of solitary confinement?
Yeah, what we have observed, and we've learned this from both hostages and from prisoners, is that you, first of all, you begin to lose the speed of thinking. You slow down to the point of needing to sleep for hours a day and yet being tired, and then it advances to a point where you can dissociate, you begin losing touch with reality. One prisoner I spoke to, for example, after 3 months, you're allowed to get a television, which he looked forward to as a chance for maybe a kind of social connection in the world. But by that point, he found the television was talking to him, asking him to kill people, and he had to stow it underneath his bunk just to be able to survive and live through this. There's no question that many of the people we confine are violent or threatening people. The vast majority of people in solitary confinement, though, are not people, and bipartisan commissions have shown this now for a while, are the majority not people who are that incredibly violent. We also learned from the British experience, where they found the solitary confinement of our IRA prisoners produced both mental damage and such torturous conditions that actually turned public sentiment against the government in that process. And so Britain went to a process of phasing out solitary confinement. They have just as much troubles with violence in their country and in their prisons, and yet they have fewer than a minuscule portion of their population in solitary confinement. And the last part of it is solitary confinement is unbelievably expensive. Managing it is 3 to 4 times as expensive. And in these moments, we have found ourselves crowding prisons larger and larger. Of course, that breeds more violence. And then that leads us to say, well, we should then put folks in solitary confinement. And we've caught ourselves in a vicious circle to the point that prison commissioners I talked to would only speak to me anonymously about this because they would get fired for saying it. But they thought solitary confinement should end.
We're going to leave it there because the program has come to an end. Dr. Atul Gawande, we want to thank you very much for being with us. His latest book is The Checklist Manifesto, How to Get Things Right. Dr. Gawande's writings are in the New Yorker magazine. He is a surgeon at Brigham and Womens Hospital in Boston, and he also teaches at Harvard. That does it for our broadcast. If you'd like a copy, you can go to our website at democracynow.org. Democracy Now! Is produced by Mike Burke, Shrifo Dokudu, Aramata, Angela Kamat, Steve Martinez, Nicole Salazar, Hani Masood, Robbie Karen. Happy birthday to Clara Ibarra. I'm Amy Goodman with Shrifo Dokudu.